Hello class, welcome to Compost Anesthesia. My name is Dr. Amol Kumar and I am a junior resident in Department of Anesthesia. So today the topic of our discussion will be on the drug ETOMIDATE. ETOMIDATE is a carboxylated imidazole containing compound. This is the structure. It has a property that it is water soluble at acidic pH and lipid soluble at physiologic pH. It comes as a solution which is 0.2% solution with 35% of propylene glycol. Nowadays, propylene glycol has been replaced with a lipid emulsion vehicle. So pain on injection and venous irritation has been almost eliminated with the use of ETOMIDATE because this component propylene glycol was actually responsible for pain on injection. All right, pain on injection. This is an ETOMIDATE vial. It comes in a 10 ml vial, okay, and each ml has 1 ml has 2 milligram ETOMIDATE. All right. Moving on, the mechanism of action. It has two isomers, the R isomer and the S isomer. The R isomer is definitely the most potent. So the mechanism of action is the ETOMIDATE binds to GABA A receptors. And what does it do after that? It increases the affinity of GABA to the receptor. GABA is a inhibitory neurotransmitter and ETOMIDATE increases its affinity on the GABA A receptor. Alright. Moving on, the pharmacokinetics of the drug. The volume of distribution is large and there is a large tissue uptake. The lipid solubility is moderate. It is a weak base with a pKa of 4.2. pKa of 4.2. It is 76% bound to albumin. And when you give a single dose of ETOMIDATE, the awakening after that is fast. It is a rapid awakening. Okay. And the metabolism of ETOMIDATE is also rapid. Moving on, we'll talk about the metabolism in detail. So the metabolism of ETOMIDATE is basically by hydrolysis of the ethyl ester side chain. The ethyl ester side chain of the ETOMIDATE that gets metabolized, and what does it form into? It forms into a water soluble pharmacologically inactive compound that is a carboxylic acid ester. It forms into carboxylic acid ester compound. And which enzymes are responsible for this? They are hepatic microsomal enzymes and plasma esterase. So both of these are responsible for the metabolism of ETOMIDATE. Approx 85% of IV dose is excreted as metabolites in the urine. Rest 10 to 13% is excreted in the bile. The clearance is more. It is approx 5 times that of thiopentone sodium. And when we compare about the elimination half time, the half time when compared with other drugs, it is the normal elimination half time of ETOMIDATE is 2 to 5 hours, and that of propofol is 4 to 7 hours. So it has a low elimination half time. Moving on, what are the uses of ETOMIDATE? The most important uses, it is used as an induction agent for the induction of anesthesia. And what is the dose which we use? We use approx 0.2 to 0.4 mg per kg IV. Okay, and similar to propofol, it also has the onset of unconsciousness occurs within 1 arm to brain circulation time. This is similar to propofol. Again, so after a single dose, there is rapid awakening, as we discussed previously. Awakening after single IV dose of ETOMIDATE is more rapid than after barbiturates. Again, like propofol, it has no analgesic action. So, like other IV agents, here also you can give opioid prior to induction, which will help in reduce laryngoscopic response. There are multiple ways which we can reduce the laryngoscopic response. One of the most common ways used is we give opioid prior to the induction. We'll talk about this point little later. There is a transient depression of the adrenocortical function. This is one classical feature of ETOMIDATE. This will be discussed further in the class. And one thing with ETOMIDATE is that the post-operative nausea vomiting incidence has increased. We'll talk about the systemic effects of the drug. So the first system definitely being the central nervous system, it constricts the cerebral vessels. So what happens if you constrict the cerebral vessel? The cerebral blood flow will decrease. So it decreases cerebral blood flow by 35 to 45%. And because of this, a very important phenomena, the ICP is reduced. So one more thing is that there are the excitatory spikes. The excitatory spikes which are seen after ETOMIDATE is more compared to propofol and thiopentone sodium. So when you give ETOMIDATE in a patient having history of seizures, you are very cautiously giving it. Alright, but it also has anticonvulsant properties. It has anticonvulsant properties, and it is definitely used in the algorithm of treating terminating status epilepticus. It can be used in the algorithm of terminating a status epilepticus. One more thing in neuromonitoring, when we see the somatosensory evoke potentials, the amplitude is augmented. Moving on, okay. Cardiovascular stability. So ETOMIDATE is an excellent drug when you want to achieve when you want to induce a case having a cardiovascular stability. So this can be done with a drug dose of 0.3 mg per kg IV. Why am I mentioning that? Okay, we have taken two doses, 1.35 mg per kg IV, 1.45 mg per kg IV. What was the induction dose we discussed? We discussed that the induction dose varies from 0.2 mg per kg to 0.4 mg per kg IV. We have taken two separate doses, 1.3 mg per kg IV and 1.45 mg per kg IV. So when you give a patient with 0.3 mg per kg IV, you can see that the heart rate, stroke volume and cardiac output had a minimal change. It was extremely cardiac stable. The systemic vascular resistance decreased definitely, but not significantly, and the mean arterial blood pressure also decreased, but up to 15%. So even these changes were not very significant. However, when you gave a dose of 0.45 mg per kg IV, there you can see significant changes in all these things. The heart rate was significantly decreased, the stroke volume was significantly decreased, the cardiac output had decreased significantly, the MAP had decreased, and also the systemic vascular resistance is decreased. So the summary is, when you give a dose of 0.3 mg per kg IV, the drug ETOMIDATE is extremely cardiac stable. Okay, why? How is ETOMIDATE different from other drugs? ETOMIDATE may differ from most other IV anesthetics in that depressive effects on myocardial contractility are minimal. It has minimal depressive effects on myocardial contractility. And you can definitely achieve anesthesia with that low dose in which a cardiac stability is maintained. Hepatic and renal function are not altered by ETOMIDATE. IOP is decreased by ETOMIDATE. And one thing is, ETOMIDATE does not result in detrimental effects when injected into an artery. This line is important because actually there is a long when there is accident injection of thiopentone into an artery, there is a whole set of list of things that you have to do. It is quite severely detrimental. You can have spasm of the artery. It could lead to gangrenous changes, and it's a very high potential risk when ETOMIDATE is when thiopentone is injected into artery. However, by mistake, if an ETOMIDATE has been injected into an artery, it is not very detrimental. Okay, talking about the ventilation, there is a depression of ventilation, but it is less than of barbiturates and propofol. Okay, and apnea may occasionally accompany after rapid IV injection of the drug. The ventilatory depressant effects is less than propofol and thiopentone. You can use ETOMIDATE when you desire a spontaneous ventilation. This is also a very important line. When you desire spontaneous ventilation, in a case you can use ETOMIDATE very safely. However, if what you do, you combine it with some opioid or inhaled anesthetics or along with some infusions, you can depress the ventilation more with ETOMIDATE. ETOMIDATE again will start acting like other drugs and it will cause ventilatory depression. Okay, this is one important phenomena which is seen in ETOMIDATE is the myoclonus. Okay, this occurs in approximately 50 to 80% of patients. Myoclonus occurs in approximately 50 to 80% of patients, and the cause behind this is what happens is there is disinhibition of subcortical structures. And what these subcortical structures do, they normally suppress the extrapyramidal motor activity. So now these subcortical structures are depressed by ETOMIDATE, and now they will not be able to suppress the extrapyramidal activity. So this is further going to cause movements in the body because of exaggerated extrapyramidal effects. This is the cause why myoclonus happens after injection of ETOMIDATE. So what you can do to reduce these effects of ETOMIDATE? One, definitely you can give atropine. What does this do? It suppresses the spike activity on EEG. Second, you can give is fentanyl or benzodiazepine. This decreases the incidence of myoclonus. And third, you can definitely give small doses of ETOMIDATE. How is this beneficial? One, no fast rapid injection. You can avoid the side effects of rapid IV infusion. Second, it decreases the incidence and intensity of myoclonus. And this topic, which this point, adrenocortical suppression, this is very specific. This is very specific.
From laptop F76S05P.
This is very specific to ETOMIDATE. So what happens with ETOMIDATE is that it transiently inhibits the enzymes which is involved in cortisol and aldosterone synthesis. It inhibits the enzyme which is involved in cortisol and aldosterone synthesis. So what happens in cortisol is basically a stress hormone. Okay, so when there is stress, the HPA axis is triggered, and what happens because of this? The hypothalamus releases corticotropin stimulating hormone, that is the CRH, and this causes stimulation of pituitary to release ACTH, and this stimulates and this stimulates adrenal cortex, and cortisol is released. So this is basically a stress response in the body, the release of cortisol. So what happens when you give ETOMIDATE? This enzyme 11 beta hydroxylase is inhibited, which is a very important enzyme in the pathway of cortisol synthesis. So when cortisol release is inhibited, the stress response is gone. So it is very detrimental in patients. It is very harmful in patients which are especially in the ICU, and they are dependent on the stress response of the body for management of their infection or whatsoever stress their body is facing. When the ETOMIDATE reduces that, this is going to be very, very hazardous for the patients in ICUs. However, other points on this is it gives a stress-free anesthesia, definitely. And one thing is that Adrenal suppression may last up to 72 hours following induction with etomidate. Last point, the patients who are experiencing sepsis or hemorrhage and who might require an intact cortisol response would be at a disadvantage, and etomidate should be avoided. Yes, exactly. So wherever there is a stress response required by the body and you give etomidate and the stress response is gone, the body is going to deteriorate. So we have to use etomidate very carefully in such situations. So with this, we end the lecture of etomidate. Hope you found it beneficial. It's a very important drug which we use, especially when you need cardiac stability. Okay, we use this in a specific dose in patients where cardiac stability is required. And that's it. Thank you so much, and hope to see you again.